When a patient reaches a state of critical respiratory failure, their own physiology can become an obstacle. The autonomic respiratory reflex instinctively fights against a forced mechanical rhythm of a ventilator. To stabilize the patient and ensure oxygen reaches the tissues, the medical team must override these reflexes and assume complete control of the airway. This is achieved by inducing a state of complete temporary flaccid paralysis. However, a specific clinical challenge arises. How can a physician safely paralyze a patient whose liver and kidneys, the organs typically responsible for drug clearance, are already failing from acute distress? Overcoming this obstacle required a class of neuromuscular blockers designed for organ-independent clearance, led by the molecule cisatracurium. Cisatracurium is classified as a non-depolarizing neuromuscular blocking agent. Its primary FDA-approved indications are to facilitate endotracheal intubation and to act as an adjunct to general anesthesia. Within the intensive care unit, it is utilized to provide sustained skeletal muscle relaxation, preventing the patient from fighting against mechanical ventilation. Physicians also apply it off-label to manage acute respiratory distress syndrome, or ARDS, where it improves the synchrony between the ventilator and the patient's lungs. It is also used off-label to control severe, metabolically taxing shivering in patients undergoing therapeutic hypothermia. This broad utility profile makes the drug a foundational tool for managing patients in the most compromised clinical states. To understand how this paralysis is engineered, we must look at the microscopic architecture of the neuromuscular junction and the motor end plate. Acetylcholine normally binds to NM receptors, opening sodium channels for muscle twitches. Cisatracurium floods the cleft, blocking acetylcholine. It binds reversibly via competitive antagonism, but keeps the sodium channel shut. Without sodium influx, the electrical potential fails to reach the contraction threshold. This differs from depolarizing blockers like succinylcholine, which cause an initial wave of muscle twitches called fasciculations. Cisatracurium maintains a quiet synapse throughout the induction. By preventing that initial depolarization, this competitive blockade ensures a fasciculation-free, flaccid paralysis. Beyond the synapse, systemic clearance is a high-stakes variable when treating patients with multi-organ failure. Most critical care medications rely on hepatic metabolism through the CYP450 system, or direct renal excretion to leave the body. Cisatracurium bypasses the liver and kidneys entirely, relying on a unique pathway called Hofmann elimination. This passive, spontaneous chemical degradation occurs directly within the blood plasma, where molecules fracture into inactive fragments dictated by physiological pH and core body temperature. Under normal conditions, this results in a predictable elimination half-life of 22 to 29 minutes, with a clinical onset between 2 and 3 minutes. This mechanism allows physicians to achieve therapeutic paralysis, even when the patient's hepatic or renal functions are severely compromised. The drug is typically formulated as an intravenous injection at a concentration of 2 mg per milliliter, providing 100% bioavailability. This dosing table outlines the weight-based protocols required for different populations. For adults, the initial intubation dose ranges from 0.15 to 0.2 mg per kilogram. To sustain paralysis, a continuous adult maintenance infusion is titrated between 1 and 3 micrograms per kilogram per minute. Pediatric patients between 2 and 12 years of age generally receive an IV push of 0.1 to 0.15 milligrams per kilogram over a span of 5 to 10 seconds. For infants aged 1 month to 2 years, the dosage requirement is more specific, set at exactly 0.15 milligrams per kilogram. Newborns under 1 month require the most sensitive titration. Due to the immaturity of their neuromuscular junctions, the off-label starting dose is lower at 0.1 milligrams per kilogram. Because the drug's distribution is limited to the extracellular space, precise weight-based calculations are a mandatory safety requirement. The absolute contraindication for use is a known hypersensitivity to the drug or its specific class. Patients with neuromuscular diseases, such as myasthenia gravis, are also at high risk. Their existing receptor deficits make them profoundly sensitive, requiring significantly reduced doses. Furthermore, protocols utilizing induced hypothermia will prolong the paralytic effect by physically slowing the temperature-dependent Hofmann elimination process. This chart compares the histamine release curve of the older drug, atracurium, against that of its purified stereoisomer, cisatracurium. Because this purified isomer significantly minimizes histamine release, it avoids the profound hypotension and reflex bradycardia often seen with its predecessor. Monitoring must still continue for respiratory complications, such as prolonged apnea or unexpected bronchospasm. The primary toxicological concern is the accumulation of laudanosine, a metabolic breakdown product that, at high levels, can increase the risk of CNS seizures. While the stereoisomer design offers a safer profile, the potential for byproduct accumulation requires vigilant monitoring in the intensive care unit. The absolute nursing priority is that this drug must never be administered until the airway is secure and mechanical ventilation is ready for use. It is also ethically and clinically necessary to provide sedation and analgesia concurrently. Neuromuscular blockers paralyze the muscles, but do not affect consciousness or the perception of pain. This is a graphical readout of a train of 4 response. By measuring 4 diminishing muscle twitches in response to electrical stimuli, providers can objectively determine the depth of the blockade. Patient teaching includes confirming they will be sedated, explaining the role of the ventilator, and warning them of residual muscle weakness upon awakening. Reversing the paralysis requires an acetylcholine esterase inhibitor, such as neostigmine. Neostigmine prevents the breakdown of natural acetylcholine, allowing it to flood the synapse and outcompete the remaining cisatracrium for receptor occupancy. This pathway reveals a key clinical distinction for patients with atypical plasma cholinesterase. This genetic anomaly causes dangerously prolonged paralysis with drugs like succinylcholine. However, because cisatracrium relies on Hofmann elimination, these patients process the drug normally. By utilizing a molecular pathway that functions independently of organ health, cisatracrium provides a predictable level of control in the most unstable clinical environments.